What is atypical glandular cells? In 1988, the Bethesda system introduced the term atypical glandular cell of undetermined significance, AGC, to describe glandular cell findings that were beyond reactive or reparative changes, but did not definitively indicate invasive adenocarcinoma. And after many years, the 2001 Bethesda system modified the AGC category into atypical glandular cells, AGC. AGC then subdivided into two subcategories: AGC-NOS, not otherwise specified, and AGC-FN, favor neoplastic. Moving to the next part, which is materials and methods. In this video, we refer to the article, The Role of the Pap Smear Diagnosis, Atypical Glandular Cells, AGC, as our main journal. In this article, 234 smears of atypical glandular cell, AGC, patients were examined from January 2002 to December 2010. The Taipei Veterans General Hospital is the source of all cases. This study also included patients who received additional diagnostic procedures or therapies. Benign or malignant pathological signs are distinguished. The precursors and malignant results are concluded as abnormal pathology. Next, we are going to look at the pathology results of this article. In 9 years of duration in conducting the studies, 234 cases were identified as AGC. However, this study included only 190 cases which had undergone sufficient histological evaluation. As we can see here, AGC smears that has the most identified subclass is AGC-NOS. However, in terms of the rate of abnormal pathology, we can infer from the data above that AGC-FN of endometrial origin has the highest rate of abnormal pathology. Here is another additional studies that we would like to included as well to somehow support the data from previous studies. Both of these studies implies that women with AGC-FN were more likely to have significant pathology compared with those with AGC-NOS cases. Next is cytomorphology of subcategories in AGC. The cytomorphology for AGC-NOS of endocervical origin. The cells are in group of cluster that loose of cohesiveness and nucleus enlargement 3 to 5 times with high NC ratio. The cells show pleomorphism which are round to oval nuclei. Other than that, nucleoli present, coarse chromatin, overlapping and scanty cytoplasm. Next, cytomorphology for AGC-NOS of endometrial origin. The cells are in small groups of 5 to 10 cells and can be seen in 3D shape. There are nucleus enlargements with high NC ratio and hyperchromatic nuclei. Scanty cytoplasm, vacuolated cytoplasm can be seen and ill-defined cell borders. Besides, cytomorphology for AGC-FN of endocervical origin, the cells in sheets with nuclear crowding, and there are combination 2 patterns of cells in one cluster. Nucleus are enlarged with high NC ratio and pleomorphism round to oval nuclei. Some parts may show nuclear elongation. Next, cytomorphology for AGC-FN of endometrial origin, the cells in small group and nucleus enlargement with high NC ratio. Hyperchromatic nuclei, small nucleoli may present and show vacuolated cytoplasm. The suggestion of all of these diagnoses is likely the same, which is to refer to a gynecologist-oncologist. However, endometrial cells are usually not further classified as favor neoplastic, as it is difficult to distinguish and frequently gives varying results. AGC-NOS has 2 different backgrounds under the microscope for the origin of endometrial and endocervical cells. For the background of AGC-NOS endometrial cells, it consists of degenerative necrotic debris, foamy histiocytes, stromal cells, and watery diathesis. Meanwhile, for AGC-NOS of endocervical origin, the background clue consists of a lot of mucin substances, mucus cells that have degenerated, and necrotic cells. It does not have watery diathesis like endometrial origin. Moving on to the misdiagnosed cases in AGC. In first cases, AGC-NOS endomet is observed. It shows characteristics such as slightly enlarged hyperchromatic nuclei and presence of endometrial debris, but, after correlating with the history of the patient, the follow-up diagnosis is determined as NALM, IUCD. In second cases, the first diagnosis came out as AGC-NOS endocervical origin due to characteristics observed, which are crowding, nuclear elongation, hyperchromatin and less severe stratification. After follow-up, the diagnosis changed to tubal metaplasia based on the location sample collected. while on third cases, misdiagnosed as AGC NOS from tightly packed uniform glandular cells and honeycomb appearance observed in the cluster. Location of sample collection confirms the follow-up diagnosis as lower uterine segment cells. Lastly, in fourth cases, characteristics observed are nuclear enlargement with high NC ratio, nucleus elongation, and pseudostratification. These characteristics were misdiagnosed as AGCFN. The final diagnosis came out as endocervical adenocarcinoma in situ. Subtypes of AGC are proved to be significant as they can be helpful to achieve precise judgment on patients' condition and pathology outcomes. Comparison of prevalence between Bethesda System 1991 and 2001 has been made through this pie chart, which prove that diagnosis of AGC in 2001 is way more detailed and specific than 1991. The pie chart concluded that prevalence of AGC in 1991 is higher than 2001. And why is that? The fall of prevalence of AGC starting from 2001 is highly due to changes made in Bethesda System 2001. Major change that has been made in Bethesda 2001 is AGC subtypes. Before the improvement, all atypical glandular cell cases fall into atypical glandular cell of underdetermined significance (AGUS), which means it is less specific and too abstract. AGC subtypes help to characterize each case of AGUS in more detailed diagnosis. Next, the importance of examination of AGC diagnosis. According to recent studies, the findings of the histologic investigation in the patients with AGC showed a strong correlation with a malignancy diagnosis. Early detection of malignancies, such as AGC, is crucial for improving survival rates and enabling simpler, more effective treatments. Furthermore, the study also mentions that based on that result, patients with AGC require cervical curettage, human papillomavirus testing, liquid-based pap smears, colposcopies, and biopsies in order to have suitable test outcomes. If initial exams are normal, further evaluation for extrauterine adenocarcinoma is recommended. Next is how significant are these subcategories of AGC. According to our main journal, which shows that the implementation of pap smear screening has increased the number of glandular cancer cases discovered, the ability to identify AGC subtypes is crucial since treating these lesions early on might give patients hope.